Yeah.
A very good evening to all the participants of Rehabilitation Science Group who are listening to the YouTube channel and watching this discussion today on fascia dynamics. Uh, and we have with us, I also welcome Dr. Sandeep Viswas. Dr. Sandeep Viswas is a graduate from Manipal University, and he earned his master's degree from Guru Nanak Dev University at Amritsar. And then Dr. Biswas relocated to the United States of America, where he did his doctorate of physical therapy. Dr. Biswas holds numerous certifications in advanced therapeutics and movement based therapies. We have with us a team member of Dr. Biswas, Dr. Nandlal Pathak, who is managing Synchrony Physiotherapy and Healthcare Services in India. I welcome you, Dr. Nandlal and Dr. Sandeep, for this occasion. Dr. Nandlal, would you like to introduce Dr. Biswas more and about the fascia dynamics? Yeah, thank you.
Thank you, Dr. Habib. So I welcome you all in this webinar, YouTube live webinar. So again, just to continue with Dr. Sandeep, so he had received many kind of certificates during his career, and kind of his quest led to the whole fascia dynamics that will be introducing you to all. So fascia dynamics is more like a 3D map that you can say. And as you know, the fascia is kind of connects everything to every organ, to every muscle, to every bone. And that's more the connective tissue framework that we have. So rather than just being a connective tissue structure, it does a lot many functions that we'll learn from Dr. Viswas. And along with that, it also has a function, which function in movement, function in, you can say, interoception, the proprioception, and all those things that is there. So we kind of trying to cover this in terms of movement. So movement, when I say, so we'll assess, we'll take the movement as an assessment tool. And then on top of that, which particular structure that you need to work on through fascia release or through fascia training. Yes, you heard it right. So we also do this, you can train fascia as well. So that's a whole lot of exercise program that is developed around fascia and its connections. So before I take a lot of time, so I'll introduce, I'll just ask Dr. Sandeep to start with today's webinar.
Okay, great. Thank you everyone for the great introduction, and I'm very happy to be with you all. I'll just go ahead and try to load up my presentation over here before we can start rolling. Okay, great. Hope everybody can see my screen. So just, before digging into the main topic of today, let me give you a little bit of story about myself. I believe if you can connect to a story, you can connect to an individual better. So as you know, Nanlal and our organizers talked about, it has been quite a journey for me going through this profession. And when I started my journey as a fresh clinician, you're all pumped up and you're ready to go. And then when you reach the clinical practice, you realize that you're actually not as good as you think. So, I had my struggle. I used to struggle with a lot of patients, and a lot of time there were, conditions where there will be a particular patterns I will notice which will be dysfunctional. It was such a frustration that, I know that something is going wrong, but I don't know what is going wrong. During that time, I know the information was not that readily available, but the courses nowadays, you see significant amount of courses coming into India. Indian PTs are doing a great job, exploring different means of treatment and assessment and stuff like that. And many PTs are also involved in educating other people in the profession, which is awesome. So that time, back then it was not as readily available. So my friends were my books. So I kept on digging. Where it was able to untangle some of the stuff, but it was such a frustration for me that, it was not working the way I wanted it to work. But anyways, slowly, as things started getting more available, I started exploring the courses. So the more and more courses I took, the more and more confused I got. Every course I will go, they will teach you what to do. Like if you take a dry needling course, they will teach you what to do with the needle. You will take a fascial course, you will be trained on how to do the fascial release. You take a manual therapy course, you learn how to do a manual therapy. But what was missing in all the courses was your ability to integrate everything and understand what to apply one of these techniques. So if you have, suppose, a big bag of tools and you're carrying it around and you don't know what tool to use to put the nail in the wall, it does not work like that, right? So you should have a pure clarity in your mindset on what you're going to use and how you're going to use it. So that frustration led to more research led to some innovation. So we slowly started organizing this coursework, and I started organizing my practice in assessing the patients better. And that's what the fascia dynamics is all about, is assessment. It's pure assessment. It's all about biomechanics. It's all about fascia, how it works, how it connects the body, and how it helps the body to move in a proper rhythm, okay? So once you take a fascia dynamic course, it's what you will get from there is how to assess an individual. And when I say an individual, I say a whole individual. You're not just assessing. So if somebody comes to you with a back pain, you're not just assessing the back pain. You're assessing the whole individual, and that's very important. Holistic care is taking a front seat nowadays, and I believe we all should get on board with it, because as a PT, we are exposed to such patients, and we have the power to influence that aspect of life. Okay. So that's a little bit about me and our journey. And this started more as a hobby to assess patients and, find out different aspects of it, intervene, fail, try again, research, try again, and we are proud that we have reached somewhere, but it's a long journey, and probably will keep going. Okay, so what our main problem is that I'm really frustrated with how fascia is taught nowadays. Okay, there are many people who are talking about it and who are exploring it, which I appreciate. But the problem is that the fascia right now is being taught as a tissue. You treat it, you teach it as a tissue, you treat it as a tissue. So when you do that, what happens? You're just treating one aspect of fascia. We all hear that fascia is a covering all around the body, which is true. But fascia is more than that. Fascia is a whole system in itself, okay? Like you have nervous system, you have your cardiovascular system, you have your skeletal system, and you have all other systems. The same way the fascia is a system, and it is not just a single tissue. Stretching it, releasing it, rubbing on it, needling on it can produce some therapeutic effect. But when you are thinking about the fascia in a more elaborate manner, you have to understand that it is not just a covering of the body. It has more into it. It has a sensory nature. It has a proprioceptive nature. It has a biomechanical aspect to it. So as we move forward with different aspects of it, you will understand that how deeply this tissue influences us. And we will learn as we go through the slides that how you can influence it and what you're missing in your practice, okay? So over the years, different authors and different researchers and practitioners came up with different definitions of fascia. There was nothing convincing, okay? So for the longest amount of time, people, for the longest amount of time, people struggled in defining what fascia is. But something which everybody agreed was that it's a three-dimensional collagen matrix, and it basically surrounds everything in your body from head to toe. It's like, if you're wearing a whole suit on your body, it's something like that. Okay. So as I said, the definition is not that easy. It is more complicated. It was so complicated, there was no consensus on how to define the fascia, okay? So when that happened, there was a fascial nomenclature committee formed in 2016. And that's when they actually put on two separate definitions. So you can understand a tissue is having two definitions just to define it, okay? So I'll read through this and try to explain you what it basically means, okay? So how they define it. So the fascial system consists of three-dimensional continuum of soft, collagen-containing, loose, and dense fibrous connective tissue that permeate the body. It incorporates elements such as adipose tissue, adventitia, neurovascular sheaths, aponeurosis, deep and superficial fascia, epineurium, joint capsule, ligaments, membranes, meninges, myofascial expansion, periostea, retinacula, septa, tendons, visceral fascia, and all intramuscular and intermuscular connective tissue, including endo, peri, and epimysium. So what it basically means, what it means is that fascia is indeed a three-dimensional tissue. When they say three-dimensional tissue, it's not something that is just an external covering. It goes deeper in. It goes to the smallest tissue in your muscle, in your bone, in your viscera, in everything you can imagine. And actually, recent studies have shown that the fascia penetrate even the cellular aspect of your body. So it goes down all the way to the nucleus. So when you're influencing this tissue, you can imagine how much of influence you're making to the whole body right till the cellular level, okay? So that's very important to understand. So get rid of that picture that fascia is just a covering and try to understand that it goes in deep into your body and has a deeper connection to every tissue you can imagine in your body, okay? So the second definition, what it says, the fascial system interpenetrates and surrounds all organs, muscles, bones, and nerve fibers, endowing the body with a functional structure and providing an environment that enables all body system to operate in an integrated manner. So very important point. So what it says here is that it is a functional structure. So it is not just a dead tissue or a covering or a sheet of your body. It is very much functional in nature, and its function actually influences every system in your body. So what it does, it helps balance every system in your body. It will help balance the your skeletal system with your nervous system, or your muscular system with your visceral system. So it forms that integrator between the different system, okay? So you need to understand that elaborate definition of fascia to understand how this, how elaborate this structure is. Okay, so Andrew Fleming is a very prominent researcher in the fascia world. So what he says that fascia is your soft skeletal system, okay? So when you say skeletal system, it basically provides the framework of the body. So we all have or had the nice skeleton buddy in our clinic, or when we were in our colleges. And for the longest period of time, we were taught that, skeletal system forms the framework of your body. Well, guess what? It does not, okay? Skeletal system just floats in the body, and it is your fascial system which provides the framework of the body and forms the skeleton of your body, okay? Fascia also forms different pockets, and those pockets will actually store the muscles or the organs and everything else, okay? And these pockets, if you will know, are not like rigid pockets. They move, like they have a rhythm to it, okay? So when the muscle is contracting and getting more slender, they actually, their diameter reduces, and when they expand, their diameter increases. And if that function does not happen appropriately, then you can have conditions like compartment syndrome. That's one of the reasons. And then what the surgeons will do is go ahead and cut the fascia to release the compartment pressure. But guess what? You could have intervened without surgery, just made those pockets more pliable so that the muscle can function better, and you could have saved a person surgery. And sometimes, compartment syndrome and stuff like that destroys athletes' career. And if you can get these patients in your hands, you can make a significant change in their life and can maybe able to return them back to their sport without any surgical intervention. Most of the fasciotomies are big failures. They don't help the patient return back. They might help normalize the pain to a certain extent, but it definitely does not help the athletes to return back to their sports. So it's very important that you should understand that how these tissues will form different pockets and are actually pliable. They're not just rigid structure, okay? And as I said, it'll cover everything. And you can see in the image to your left, you have the fascia covering the muscle. You have the fascia covering your organ system. And if you go in a little deeper, you can see the fascial sheath actually covering the nerves too. So they can actually influence the nerve mobility too. So radiculopathy patients, you need to check the fascial mobility around the nervous tissue to see if it's pliable enough to let the fascia glide. Okay. Then you have your adipose tissue, which is again surrounded by fascia. Okay. So as I said, and I have been reiterating it again and again, that fascia is basically a tissue and a system. Okay. So when we see a more elaborate picture of it, you need to understand that it has both histological or morphological aspect, and it also has a functional and sensory aspect to it. Okay. And before we move forward, first of all, what we'll do is go to the initiation of everything and go back in time and begin where everything starts. Okay. So the fascia basically starts forming in the mesoderm. Okay, so it's around 2 to 3 weeks of embryo formation when the blastula will start dividing and go through a process called gastrulation, and then it will form 3 different layers: your ecto, meso, and endoderm. Okay, so mesoderm is the middle layer, and as you can see in the image, it not only is suspended between the ecto and the mesoderm, but it also surrounds the ecto and the mesoderm. So you can see the organization of fascia begins way back in the embryo formation, and it actually guides in the formation of shape and shaping of the different system. Okay. So again, going through the different layers, just giving you a little bit of idea what different layers does. So you have your ectoderm, which is the outermost layer, and it will form your nervous system, brain, skin, tooth, and enamel. Your mesoderm is where your fascia will start. Okay, it also forms other structures like smooth, cardiac, and skeletal muscle, your mesentery, bone, cartilage, red blood cell, dura mater, and notochord and microglia. Okay, the endoderm is the innermost layer, as I said. It forms all the other system like the digestive, respiratory, liver, pancreas, and other endocrine systems. Okay, now we know where it all originates. Okay, you have a basic understanding of fascia, what it is. Okay, now let's go and understand what's the composition of fascia. Well, you will be amazed that fascia is such an extensive tissue, and still being an extensive tissue, it just have 5% cells. So rest 95% is just extracellular matrix, or what we call more fluid-like structure. Okay. So 95% is extracellular matrix, and there is just 5% cell. Can you imagine such an extensive tissue connecting everything in your body? And I have been bragging all about it, that it does this, it does this, it has so much of function, and it's just formed by 5% cells, and rest all is extracellular matrix. Now you'll understand why that happens in your body. Okay. So let's just dig in a little bit deeper and understand what this extracellular matrix means and what kind of cells the fascia has. Okay, so the extracellular matrix contains 3 different structures. So you have your collagen over here. So it is a triple helix collagen. Okay, you have your elastin fibers, which are stretchable fibers, and then you have your matrix. Okay, so matrix is basically fluid. Okay, it has an egg white like consistency. So if you take egg white and put a triple helix thread into it, and then you put some rubber bands into it, that's what your fascia is. Okay. And then what you have are these pink dots over here, which are fibroblast. Okay. So you have extracellular matrix, which is made up of matrix, or what we call ground substance. And then you have elastin and you have collagen into it. Okay. And the cells are basically fibroblasts. So what are fibroblasts? So fibroblasts are cells which helps in repair and regeneration of the fascia. Okay. So they are basically the construction worker or the maintenance workers of your system or of your body. So whenever there is a problem, they will come in and do the repair work and, fix things and make your body better, okay, or heal the injuries and stuff like that. So that's what the function of fibroblast is. There are other cells also, like in any other tissue, you have your nerves and vessels and mast cells and other inflammatory cells, okay? But what you need to remember are the fibroblasts. That's most important, okay? Now, coming back to the ground substance, as I said, it is made up of collagen, elastin, and some matrix. The matrix is basically made up of proteoglycans, glycosaminoglycans, and hyaluronic acid. So these are the 3 basic structure which forms the ground substance, okay? So you have to understand this. These glycosaminoglycans and proteoglycans are basically hydrophilic in nature. So what they will do whenever there is a swelling, they are like sponge tissues. So they will absorb the swelling and will grow in their size. Now I'll give you a good example of it in the clinical aspect. So suppose a patient comes to you post-injury or post-surgery. What happens? You see a lot of swelling. Why that swelling happens is that these glycosaminoglycans start absorbing all the inflammation around your tissue, okay? So when they absorb the inflammation, what they do is they grow in size. When they grow in size, they're not able to pass through the lymph vessels. When that happens, they start accumulating, okay? And then we as clinician, what we do, we squeeze these cells. So try squeezing out some fluid from these cells so that they can pass through the lymph vessels, okay? So you do some lymphatic drainage, or you do some kinesiotaping and stuff like that to reduce the swelling, okay? So that's how, see how you can influence tissue at the cellular level. It's very important. So in patients whom you see swelling and inflammation and something is not getting better, you need to address the fascial aspect of it, okay? Then you can get probably a more rapid change in recovery, okay? Now coming back to our most important friend, the myofibroblast, okay? So fibroblast, as I said, are the building blocks of your body, okay? They are the repair worker or the maintenance worker, okay? So again, coming back to the clinical aspect of it, you know, we all treat frozen shoulders or low back pain patient, and what we are taught to do is fight them, do this, do that, needle, whatever, stuff like that. But you know what happens in a frozen shoulder is that there is a change at the cellular level. So the myofibroblast or the fibroblast are not functioning in an appropriate way. So that's what is leading to the freezing of all the soft tissue structure or freezing of the capsule and everything else. And no matter, and I don't know if you have faced this problem, but there are patients who are just notorious not to get better. Okay, you keep on gliding them. They come in with 100 degree. After 3 weeks, they're still 100 degrees. Why is that happening? Because the problem is not at the tissue level, the problem is down at the cellular level. So what you have to do is fix problem at the cellular level. So what you can do is align the tissue in a particular way, and we teach it in our classes where you can align the tissue in a particular way, where your fibroblast activity gets better, okay, and they start forming the healthy tissue instead of getting the soft tissue to tighten up more, okay? So you can see how you can influence the cellular level, at cellular level to get the change at clinical level, okay? And this is a very good study done by Meltzer in 2019, explaining or proving what I'm trying to convey over here. So what he did, he took fibroblast, okay? So he took fibroblast, put it on a tissue, like a jam on a bread, and then he observed them. So what he did, he observed the fibroblast in a healthy tissue and see how healthy they look, okay? And then he gave repeated strain to that tissue and see how the fibroblast gets broken off and it does not look very healthy, okay? Then what he did, he performed myofascial release and see how the fibroblast reorganized, okay? And you can see on the slide just under it on the left side, this is again the control, and without injury, he performed myofascial release, and that also increased the fibroblast activity and made the tissue healthier. So, you know, in athletes, they will undergo some soft tissue work before they go on field or participate in their athletic activity, which has shown to improve their performance. So this is the reason, because that has improved the fibroblast orientation, okay? So repetitive muscle strain, fibroblast not healthy, perform myofascial release in a particular way, and you can see how the fibroblast growth has improved, okay? And imagine applying this concept in your frozen shoulder patient or patients with back pain who are not getting better, or any other patient, you know, you're having problem with, okay? So now you understand what the tissue composition of fascia is and what fascia is in itself, okay? Now let's come to the properties of fascia. There are many properties of fascia, but what I'll focus on today are two properties. Those are the pixotrophy and the tensegrity, okay? So pixotrophy is the property of a tissue to change from a fluid to a solid state and from a solid to a fluid state, okay? So why this is important? Okay, when you have a restriction of motion or when you have tissue that is tight, it gets more solid or more rigid. Okay, and when you apply your therapeutic intervention, what happens? It changes from more solid state to a more fluid state, and fluid is always good. Like fluid is kind of correlated to motion. So you say the motion is very fluid. Why do you say that? Because fluid is more pliable, it moves better, it's smooth. Okay, so when you're performing your myofascial treatment or training or whatever, you should focus on influencing this property of fascia. The next thing which you need to understand is the tensegrity model. So tensegrity model, what it means is that you have tension areas and then you have your compressive areas. So tension areas are your bones, okay? Or the compressive, the compressive areas are your bones, okay? And these are connected by what we call tension bands. So tension bands are your fascial sheaths. So suppose you have two bones suspended like this, you will have fascia coming and connecting them. And what it does, it helps in motion and dispersing the forces which are acting on a particular region. So you can see on the image on your left, when the person is compressing that tensegrity structure, it kind of disperses all the force. If that is not happening, if the dispersion of force is not happening properly, what you will have problems in the joint, you might have problems in the soft tissue. Okay, suppose a patient comes into you with osteoarthritis, okay? There's medial joint osteoarthritis. What is happening? The bones, as I said, are suspended. Bones don't connect to each other. If they're connecting to each other, there's a problem. They are actually suspended in space. And how they are suspended is through fascial tissue, all the tension bands. Okay, so suppose this is your knee joint, okay? This is your medial aspect and this is your lateral aspect. Suppose the medial aspect or the medial tension structure or the fascial structure is tight. What it will pull the joint like this, okay, and compress the joint line. And if it's too weak, what it will do? It will make the joint to go the tensegrity structure works, okay? And a lot of times, if you can get, again, as I said, you have to get the patient at the right time. If you get the patient at the right time and you influence these forces with your intervention, doesn't matter if you're doing a myofascial work or you're doing needling or doing whatever, and then you're training the right aspect of it, you should be able to, balance the forces, reduce the inflammation, reduce the compression in the joint, and, get structural change and also influence the pain. Okay, now let's go to the different layers of fascia. So how fascia is, it's suspended in different layers. So you have your skin, then you have your adipose tissue, you can see over here. Then you have your superficial fascia, then you have your deep fascia, then you have multi-layered structures of the deep fascia. So the deep fascia is not just, a single sheet. It has multiple layers to it. And in between these layers, what you have are loose connective tissue. So when I say loose connective tissue, it's just the fluid matrix, or it is the lubrication you have in between the different layers. If you don't have this lubrication, what will happen? The fascial layers will stick to each other and then you will have a problem. Make sense? Okay, so in the end, you have your muscle or the epimysial layer of the muscle. So again, skin, superficial adipose tissue, you have your superficial fascia, you have your deep adipose tissue, then you have your multi-layered deep fascia, and between your multi-layered deep fascia, what you have a lubricant. This lubricant is called hyaluronic acid, which helps the tissues to slide properly in between each other. And then finally, you have your muscle tissue. Okay, this is a categoric view of the same, and you can see over here, skin, adipose tissue, superficial fascia, then again adipose tissue, then you have your deep layers, and finally the muscle fiber. The same is an ultrasound view over here. You can see skin, superficial fascia, superficial adipose tissue, you have your superficial fascia, then you have your deep adipose tissue over here, and you have your deep fascia, and finally your muscle fiber, okay? Okay, now coming to the deep fascia. So as I said, deep fascia is basically made up of 2 to 3 layers, okay? And in between each layer, there is a lubricant. This lubricant is called hyaluronic acid. And as I said earlier, the lubricant has a consistency of egg white. so that it lets it slide. But what happens with injury or immobilization, this consistency can change from being in an egg white state to being more like a honey-like consistency. So it gets sticky. So when it gets sticky, so suppose you have these two layers, suppose this is layer 1 of fascia, there's layer 2 of deep fascia, okay? You put egg white in between them, you can slide them. Now, if you put honey in between them, what it'll do, it'll stick the two sheets. Then you won't be able to move it, and eventually if you try to force it, you might cause a tear, okay? So it's very important that the fluid between that, or the lubrication in between that, in between different layers, remain in an egg white state, okay? And that's the consistency you want there. You don't want it to change to something which is thicker. Okay. As I said earlier, again, the fascia has tremendous amount of sensory fibers into it. It has raphenes and Pacinian corpuscles and everything else you can imagine. So it plays a big role in proprioception too, okay? And again, let's dig in a little bit deep into the hyaluronic acid. So you can see in the deep fascia, you see these white layers. This is actually hyaluronic acid. This is what helps slide it. If the hyaluronic acid is not working properly, again, the tissue will stick together, okay? Okay, now coming to the different types of fascial dysfunction. So what are the different types? There are two basic types of dysfunction. You have your fibrosis and you have your densification. Okay, so what happens in fibrosis? So fibrosis, there is a change at the level of the collagen. Okay, so there is a problem with the collagen. So you have around 15 different types of collagen, but 3 most important ones are type 1, type 2, and type 3. So there is a problem between these, within this collagen tissue. And when we talk about densification, the problem is at the level of connective tissue or at the level of hyaluronic acid. So what happens, as I explained earlier, the hyaluronic acid will change from more egg white-like consistency to more honey-like consistency. And when that happens, the tissues are not moving properly. Okay, so how can fascia become a source of pain? So fibrosis, again, as I said, there are 2 types, fibrosis and densification. The fibrosis can happen due to 2 reasons. The first is due to immobilization. So suppose a patient comes to you post-surgery, the patient is immobilized. What happens? There is a change at the connective tissue level. So there might be excessive production of type 1 collagen. Okay, what it will do, it will thicken the fascial layer. So you can see an image from a study. You see this is gastrocnemius when the patient is mobilizing, and this is a patient when he is immobilized. You can see how the collagen fibers have thickened up. You see that? And this will cause problem. Now, the other reason of fibrosis could be overuse. So sometimes you see athletes or patients who are doing certain motion repeatedly, and that causes an injury. So why does that happen? So what in such situation, what happens is that there is a change in collagen formation. So there is either dysplasia. So by dysplasia, I mean the collagen is not forming properly, or there is hyperplasia. So there is lot of formation of collagen. Both of them, what it will do, it will lead to alteration in fascial force. So again, I like to talk a lot about clinical aspects of things. So here is again a clinical aspect of things. So we all see patients coming in with suppose patellar tendinopathy or patellofemoral pain syndrome. What happens in these patients is that the patient probably is using an improper mechanics, and he keeps on loading a tissue in a proper way, or in an improper way, sorry. Being a little bit more specific about it, let's say this is your, suppose this is your kneecap. It's not ideally a kneecap, it's more like a square-like structure, but just, use your visualization a little bit with me. So suppose this is your kneecap, okay? You have your 2 muscles. You have your vastus medialis, and then you have your vastus lateralis, okay? Sometimes what happens, the patient keeps on using their vastus lateralis, and what it'll do after a certain time, it will lead to the alteration in the fascial forces, okay? So when there is an alteration of the fascial forces, what it'll do, it will tilt the kneecap in an abnormal pattern, okay? And that's when they will start experiencing patellofemoral pain or patellar tendinopathies and stuff like that. So all you have to do is that balance these 2 forces, okay? So release this one, which is overactive, and train this one, which is underactive, and boom, you get the patella to where it should sit. Okay. So that's a fibrosis with overuse. Okay. Now coming to the densification. So how does densification happen? So when you do, suppose, a lot of exercise, okay, or you train abnormally, or you do repetitive movement, which is not healthy, what it will do, it will lead to reduction in pH. Now, this reduction in pH influences the viscosity of hyaluronic acid, or that egg white-like structure or fluid in between your different layers. What it does, it increases its viscosity, so it becomes more sticky. Okay, when there is an increase in viscosity, what will happen? There will be an increase in adhesion between the fascial layer. Now, what this will do, it will damage the proprioception of the tissue, which will eventually lead to movement dysfunction and will finally lead to pain. Okay, that's an dysfunction due to densification. Now, it's very important to understand that why we are influencing, or why our program is based so much on movement. Well, fascia is very important for movement, and movement in itself is very important. Movement is important for expression. Movement is important for communication. Movement is important for survival. Movement is important for everything you do throughout your day-to-day activities. Without movement, there is no life, right? So it's very important to understand, if movement is so important, we should be treating the movement, and we should be trying to balance the movement rather than just influencing a particular tissue. And let's now understand why fascia is so relevant to this movement, okay? So Robert Sklype is one of the prominent researchers in the fascial world. He does a lot of work on how to train the fascia, okay? What he suggests is that fascia can actually contract independently of muscular action, okay? So you don't need a muscle action to contract a fascia. Actually, it's the other way around. So you need a fascial contraction to produce a muscle function, okay? And there is no way you can contract a muscle singularly. There's no way you can. There's no way that you can bend an elbow and say that it's just the biceps working, there's nothing else working. Well, you can put your hand, other hand on your chest around the pec and see if when you're flexing your elbow, you will feel a movement in the pec too. Why is that happening? This is happening because there is a fascial pattern which influences that. And all these fascial patterns are connected with similar types of motor units so that they talk to each other and they coordinate with each other, okay? And also what is important to understand is that when you do a muscle contraction, actually 40% of the muscle force is lost to the vicinity. So suppose you're contracting a biceps, 40% of force is lost to your triceps, your brachial fascia, your deltoid, and all other tissues surrounding your biceps. You never send the whole force through the muscle. Why is that important? It is important because if you send the whole force through a single muscle, you will end up rupturing the muscle. So suppose you're doing a biceps curl using a 10-kilogram weight, actually only 6 kilograms of weight is going to your biceps. The rest 4 kilograms is actually spread around all other tissues in the vicinity. And it is very important. Okay, if that does not happen, so you're not influencing the structure or the efficiency of the system. Now we talk about agonist and antagonist and stuff like that. Well, they're true, but that's a very old concept. It's not about agonist and antagonist and stuff like that. It is how the forces are dispersed through these different muscle groups, okay? Now think about doing your MMT next time. When you're testing the muscle for 4 plus or whatever, you need to understand it's not a pure muscle you're testing. It's the whole fascial continuum you're testing. And maybe, I don't have evidence supporting it, but maybe in future I will. The MMT, just doing a single muscle MMT, I don't think it makes any sense, at least for me. If I'm able to change your thought process at the end of the lecture today, I'll be, I'll tap my back a little bit, okay? But for me, it doesn't make sense. So that's why we use more movement-based assessment and strength assessment rather than just focusing on single muscle testing, okay? And finally, what you should also understand is that movement is complex, okay? Movement is not linear, it is more complex, it is three-dimensional. When you're moving, there's a lot happening in your body. Okay, so when you are using your shoulder, it's not just your shoulder you're using. There are other structures which are trying to, adjust to this motion. So when you're moving, your ribs are adjusting, your lungs are adjusting. There's a lot happening. It's not just one tissue that is getting influenced. It's not just your musculoskeletal tissue that is causing the movement. Okay, so giving you, again, digging in a little bit deeper, so you can see, I like this example. So again, if we can talk about frozen shoulder over here. So this structure you see over here is brachial fascia, okay? And this over here is the pec. So you can see how the pec continues with the brachial fascia. And then you have your latissimus dorsi over here, which again continues with the brachial fascia. Again, a similar image you can see over here. This is your latissimus dorsi, this is your pec, and see how it merges to the brachial fascia, okay? So whenever you are doing a latissimus contraction, you are actually influencing the pec, and when you're doing a pec contraction, you're actually influencing the latissimus dorsi. Sometimes you will see patients post breast cancer or chemotherapy or radiation therapy, they will have a strong cord-like structure over here. What is that? That is not scar tissue. That is actually your brachial fascia getting taut because of improper orientation of your pecs and your latissimus dorsi, okay? Now the brachial fascia doesn't end over here. You have your deltoid, which will attach to it. And you won't believe it, deltoid has like 80% of deltoid muscle attaches to the fascial sheet. It does not have a bony attachment. Similar thing happens in the gluteus maximus too. So 80% of gluteus maximus has fascial attachment. It does not have bony attachment. You can pick up any recent anatomy study, you will see that. Okay, so it's trying to throw your old anatomy books out, where you see the muscle has an origin from this bone, will go to this bone, and blah blah blah, whatever. It does not. It's a whole continuum, and as you can see with pictures over here, which are dissected by experienced anatomists, and you can see how the brachial fascia gets influenced by your pec and by your latissimus dorsi and also by your deltoid muscle. And again, giving you another clinical pearl, what happens through the brachial fascia, you will have your median nerve, ulnar nerve, and your vessels or the brachial artery passing through these region. And sometimes you will see patients with radiculopathy getting 1,000 scans, nothing showing in the neck. You're doing tremendous amount of work in the neck. You're doing neural glides, you're doing needling, you're doing taping, what else and what not, but you're still not able to change the symptoms. The patient ends up going under knife, gets a surgery. Still, he still has a radiculopathy or still has a carpal tunnel. You need to check the brachial fascia too. Check the brachial fascia, see if that is restricted. Maybe that is clogging the nerve. And it happens, I see in so many patients, is that they are diagnosed with cervical radiculopathy, and they come in and I test their brachial fascia. Actually, it's the problem with the brachial fascia. Their neck was completely fine. I do a brachial fascia release, they're good. They're good to go in a couple of sessions, okay? Okay, now again, what is important? So that's about a little bit of how the fascia will interconnect and how it influences different structure in your body, okay? Again, what is important is that fascia has an ability to recoil. So when you load a fascia, it should recoil. If the recoil does not happen properly, what happens? You have an injury or you have a problem, okay? And the recoil depends on good hydration. And by good hydration, I don't mean drinking lots of water. Well, yes, drinking water has an influence, but good hydration, I mean the hyaluronic acid between the different layers. So if you have a good hyaluronic acid and your fascia has a good recoil and they are sliding properly in between each other, you're fine. You won't have any problems. Okay, now you have to understand that fascia is also very, very, very sensory in nature, okay? It has actually 6 times more mechanoreceptors than your skin, okay? So it's very important to understand that it has a neural influence too on your system. And you can see these are 4 most common mechanoreceptors in your fascial system, okay? And depending on what kind of mechanoreceptors you are influencing, your treatment methodology will change. Okay, so I'll just go through and run through them briefly, introduce you to different aspects of these mechanoreceptors, and then give you an idea how you can influence these different mechanoreceptors. Okay, so the first one is the Golgi. By the way, I like this image, this cartoon. It kind of gives a character to all these mechanoreceptors, and as I'll talk to you about these, you will understand why these images make sense. Okay, so first one is the Golgi tendon organs. Okay, so these are present in deep fascia, ligaments, and myotendinous junction, and what they respond to is deep pressure and strong stretches. So when you're doing a deep pressure or you're doing a strong stretch, you're influencing these tendons, and that's why you see that bodybuilder who likes nice strong things. Okay, the next one, the crazy guy, is the Pacinian corpuses. Okay, so Pacinian corpuses are again present in the myotendinous junction. They're present in the joint capsules. They're present in spinal ligaments. They surround some of the muscular tissue, and some other proprioceptive regions in your body. Okay, how they respond? They respond to sudden pressure. So if you give them a sudden pressure, or you give them a nice rhythmic dancing kind of intervention, they like that. So Pacinian corpuses will respond to that kind of intervention. Okay. Next, you have the Rufinese corpuscles, which are the elite people. They are present in skin, dural membrane, ligament, and joint capsule. And what they do, since they are elite, you cannot just shake them or pound on them. You just need to apply slow pressure or very slow, gentle stretching. Okay. Finally, you have the group of these crazy interstitial sisters, or the interstitial cells. These are very important. Why? Because they influence the sympathetic nervous system. Okay, so when you treat or intervene on the interstitial sisters, they actually increase the vagal tone and might help you reduce the blood pressure and heart rate. Makes sense? So sometimes people who do craniosacral kind of stuff, where the intervention is very gentle, very rhythmic, you're actually influencing this interstitial sisters, and that's why sometimes you feel or you see the patient is feeling calmer, more at peace with this, or more in homeostasis with this body. Okay, so these will influence your sympathetic nervous system. Okay, so when you understand, when you're treating the fascia, is just not pounding on the fascia, or just rubbing on the fascia, or needling the fascia, or taping the fascia. You have to intervene it in a proper way. You have to understand it. When you understand somebody, you talk to them in an appropriate way, or you communicate them with an appropriate way. Same, with the fascia, you have to communicate them with the proper way to get the desired change you want from that system. Okay, again, coming to another clinical pearl, you need to understand that let's talk about low back pain. Okay, let's talk about low back pain. It's one of the very common condition you will have. So I believe all PTs treat a lot of low back pain and a lot of chronic low back pain. Now, let me tell you something. In chronic low back pain, what happens? There is a change in the type of cellular activity that is going around. Okay. When I say that, what happens? Your back has a lot of sympathetic nerve fibers, or a lot of proprioceptors. When you have chronic low back pain, actually these nerves, or the proprioceptive nerves, will reduce in number, and what will happen? The pain-producing cells will increase in number. So when you're trying to treat these patients, every time you do something, there is pain. You ask them to bend, ouch, there is a pain. You ask them to rotate, ouch, there is a pain. Why is that happening? Because all these proprioceptive cells have died, and all these pain-producing cells have increased their number. All the response that is coming from the tissue is pain, 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 pain. Okay, so you have to understand that if you can influence the proprioceptive aspect of it, or if you can influence all the cells we just talked about, the Golgis, the Rufinese, the interstitial sisters, or the Pacinian corpuses, you can actually make a very dominant change in your chronic pain patients, or in your chronic low back pain patients. Okay, so you just have to intervene. You have to diagnose the patient properly, put them in the proper category, and then intervene in an appropriate way to cause the desired change. Okay, so how a fascial dynamic system is important. There are other fascial systems which are available in the market. We have Tom Myers. We have Stecco's myofascial sequence. Tom Myers, I admire him a lot. Stecco, I'm a big fan of all his clinical work. I constantly follow them, read all their articles, whatever they publish. Okay. The problem with the anatomy trains or Tom Myers concept is that he just focuses on particular lines. Okay. The body is not that easy. Body just don't work in a particular muscle sequence. Okay. There is more to it. And also when he is assessing the patient, it is just based on static observation. He never does dynamic testing, or very few dynamic testing. So when you do that, you are missing on a big chunk of fascial information. Okay. The Stecco's is a more, he does a very good evaluation. His is more comprehensive, and he does great myofascial work. But what is missing in his concept is that there is no training of the fascia. And how we teach fascial dynamic system is that we try to influence both aspects of it. You cannot just release every tissue. Sometimes you need to train them too. Okay, we need to put them in proper category. Okay, fine. This is the patient I need to treat. This train. This is the patient I need to release, or this is the patient I need to do both, or this is the patient I cannot do anything. So you need to categorize those patients. Okay. Fascia is not just about release. And as you saw, and I talked to you about it, how the force transmission happens and everything kind of coordinates with each other. Sometimes the patient doesn't even need release. You just can treat them or train them in the appropriate manner, and you will have the desired change you need. Okay. So what we do a more elaborate classification of the fascia. So what we do, we kind of put them into 4 different categories. The first one is the linking fascia. So you have 2 types of link. There are dynamic links and there is passive link. Then you have fascicular fascia, which maintains the nerves and the vessels. So they provide the patency to the nerves and the vessels. Then you have your compression producing fascia, like, in your calf muscle, you have those different compartments or, muscle pockets, which will help give it a form. So, and they can also help provide compression to those tissues. Okay. Then you have your separating fascia, which will kind of compartmentalize different organs and tissue system in your body. Okay. So that's how we differentiate them. And also what we do, we then categorize on what kind of, cellular proprioceptive control loss the patient is having. Okay. And then we intervene appropriately. Also, it is as I was talking about proprioception so much, it is important to understand that when you are training the proprioception, we train joint proprioception, right? You need to understand that joint proprioception works just in the terminal ranges, okay? When you're working in the mid-range, it's not joint proprioception, it's fascial proprioception. So as you're training joint proprioception, and sometimes you might see it in your patient that you're training joint proprioception, you're training them for balance, the balance does not improve. Why that is happening? Because you are just focused on the joint proprioception. You haven't trained the fascial proprioception, which is more active in the mid-range of motion. Okay, so when you train that, you will have a more comprehensive and even faster recovery of your patients. So appreciate that. Okay, appreciate the role of fascia in everything you do. Even if you take this concept to whatever you are doing right now, you will see tremendous improvement in your practice. Okay, again, Still is the father of osteopathy, and way back, way back, this is Still's work is around in 1800s. He said that body is actually a unit of function. So as I've been reiterating again and again, what we focus on is function. And you can see on this image, the fascia kind of lines or the layers line on each other at a particular angle. And if these angles are gliding and sliding in an appropriate way, they influence the function in an appropriate way. Okay, there is again an image of an athlete or a javelin thrower. You can see how the fascial layer will integrate and produce the motion. This is an image of thoracolumbar fascia, and we teach these forces in our fascial, in our lumbopelvic coursework, where we help you diagnose each force production and how they kind of coordinate to the movement. And you can see there's so many forces acting in the thoracolumbar fascia. When you dig in deeper into the thoracolumbar fascia, there's so much to explore. It's a whole 4-hour talk in itself. And there's so much going on there, okay? And if you know how to diagnose these forces and you know how to align these forces, you will be able to fix your 80% of your complex patient. I'm not saying the easy ones. I'm talking about the complex patient, the patients who have exhausted all resources. So how we do it, how our plan goes, so we focus a lot on the history. So you start with detailed history, then you identify the system impairment. So it's very important that you identify the system that is influencing the problem. So sometimes it might be a red flag. So if it's the cardiovascular system, it's not your patient. The patient needs to go to the ER, right? So it's very important to assess that if it's the fascial system, it is the musculoskeletal system, it is the visceral system, what kind of system impairment you have, okay? Once you know it's within your scope of practice, what you do, you perform specific assessment. So what you do, you observe, you palpate, and you do our fascia dynamic motion testing, okay? And then what you do, you identify the dysfunctional pattern, okay? Once you identify the dysfunctional pattern, you determine the region you need to intervene, okay? Or the movement you need to fix. Once you do that, you intervene, and then what's very important is you need to retest, okay? So again, the whole structure is based on function. So if a patient comes to you with low back pain when he's bending, you just not fix the low back pain, you have to fix the motion. So you have to fix the patient ability to bend forward without influencing any low back pain. Okay, so here are some clinical examples. So this is a patient who was supposed to undergo surgery, and thankfully I was able to pull him out of it. So you can see there's a dysfunction in the fourth generation from the thoracolumbar fascia, okay? So you can see when he's standing on the right leg, how his erector spinae pops out, and there is so much of creases in the thoracolumbar fascia. There is no stability at all, okay? When he stands on his left leg, though, there is better orientation of soft tissue, okay? The patient was trained. He needed both myofascial intervention, so we did some releases, and I did some training for this patient with, eventually he was able to return back to his sports. So this is a US ski team athlete, and here I'm testing one of the motion testing we do, and you will see how the patient struggles with her stability of the fascial lines. So she's trying to do a cross crunch, and she will try to extend her leg, do everything possible to achieve that motion, and she was weak on both sides. Okay, here you see a case study. So you see the patient came in with right shoulder pain and right-sided neck pain after he threw a ball, after which he started having these symptoms. And you can see how the fascial forces are not aligning properly over here. And you can see, this is again one of the fascial dynamic motion testing we do is a push-off test. So you can see on the left side how the scapula is oriented, and on the right side you can see how the scapula is winging. So when you see a scapular winging, what our response is, okay, say train the serratus, that's the weak muscle, okay? But when I digged in a little bit more, you can see there is a force distribution pattern alteration. So there is a problem in the pec minor, okay? So the pec minor was the one which was causing an alteration of the force mechanics. The patient, the intervention was performed, and same day the pain was down to 0, and you can see the change in the structural orientation of things, okay? And also you can see how the winging of the scapula reduced significantly. Okay, this is a patient came post lumbar L4, L5 lumbar fusion. She was in tremendous amount of pain, not able to bend down. You can see on the image to your right side, and you can see how the thoracolumbar fascia is not letting go, and there is no reversal of lumbar lordosis. So you can see almost a flat table-like orientation of the lumbar spine. Okay, this is a patient which again needed some releases and also some training. What we did, we tried balancing the different forces. So these were the forces which were worked on for her. And you can see this is pre and post session. And you can see how this was over here. And you can see the nice change in the orientation of lumbar lordosis. Okay. This is a patient post rotator cuff repair, was struggling to achieve, as I said, again, it should be very functional. He was having problem reaching behind his back. Performed the push-off test. The left side is the dysfunctional side, by the way. So perform the push-off test. You can see what happens over here. There is an overactive force alteration between the rhomboids and the levator. And this patient had to be trained to reorient the fascial forces. So retraining was done. Inhibition of the rhomboids was done. Force balancing of the latissimus and teres minor and lower trapezius was done. And this is pre and post session images, okay? So as I said, you can make both functional and structural changes, and you can see in this patient with some scoliosis over here. And after a couple of sessions, see how you can make the structural changes. So it's very important. If you're getting the right assessment, you can do the right intervention. And when you do the right intervention, you can influence both the structure and the function, okay? And you can change the mechanism of the human body in itself. It's very holistic, okay? So yeah, that's all from my side. And here's my contact. If you have any questions or queries in future, reach out to me. These are our websites and all the social media platform. Go ahead and follow us on that. We post a lot of good information. We will be starting to write some blogs pretty soon. So you will, I assure you, you will read stuff out of the normal books kind of a thing. But we put in a lot of effort on organizing our all our content. So yeah, go ahead and subscribe us. Okay, great. So any questions? Go ahead and shoot it.
Dr. Sandeep. Thank you, Dr. Sandeep, for enlightening us about the fascia. Definitely, we could come to know lubrication is important between the layers of the different fascia, and definitely the fibrosis and the densification is the main facial dysfunctions are there, which we physio should be looking after for this thing is there. And thank you for enlightening it, how there is this increase and decrease in the viscosity part is there, and we should go for the dynamic testing of the fascia. A little question comes in my mind, Dr. Sandeep. There is a Janda is also there, and Janda used to go for the faulty movement pattern, and he used to say the things with the muscles are doing the faulty movement pattern. So is it the same thing, or is it any difference is there? What we could say?
Okay, so a very important point you need to understand, and when I was talking about in my lecture too, is that you cannot have a muscle contraction without a fascial contraction, okay? But you can have a fascial contraction without having a muscle contraction, okay? That's very important. I appreciate Janda's work, and the problem with the Janda's work is that it is very structural based. So you talk about lumbar lordosis, or you talk about cervical lordosis, or you talk about the other aspect of it. And there is particular muscular patterns he talks about, like there is tightness in the extensors or hip flexors, and then there is weakness in the abdominal muscle. The problem is that the fascia is not that absolute. Okay, if you talk about muscular sense, yes, you can make it absolute, but the body does not work in muscular sense. Okay, it works in a coordinated coordinated connection between different fascial layers which constitute of different muscles. Okay, so it's not as pure as just being in lumbar lordosis and just being in flat back position. Just giving you a little bit more input into it, the lumbar lordosis does not happen just because of tightness of your lumbar extensors. Okay, it can happen due to pure, and we talk about it when we do our thoracolumbar fascia training course. It can happen due to improper orientation of your diaphragm. Okay, what it does, it throws the TL junction into an instability, and to stabilize that, your lumbar lordosis increases. So you try to kind of, hyperextend yourself, to lock yourself in your particular position to achieve the stability. Okay, so it's not as pure as just being in lumbar lordosis or flat back position. Okay.
Yeah. Thank you, Dr. Viswas. And tell me the treatment strategies, a few strategies for this loosening of the fascia, what we can do.
So when we talk about treatment strategies, you can pick any treatment strategy. If you like to needle, go ahead and needle. If you like to do soft tissue instrument assisted stuff, go ahead and do that. If you like to tape, do that. If you like to work with your hand, do that. The first thing you need to understand is where to intervene. Okay, how to intervene that tissue.
Okay, we can use any tool. The main thing is first is assessment. Any tool you can use it. Okay.
And definitely when we do, and when we do our courses, I teach you how I do it. You are free to use it. I also give you tips on how you can use the other instruments to do the similar release. It's up to you. That's how you want to release it. It's everybody's comfort. We don't try to influence that aspect.
So definitely our viewers would like to listen about the next lecture, how to go for assessment, the dynamic assessment of the thoracic lumbar and the different fascia part. And definitely we would like to invite you for the further treatment strategies. Thank you, Dr. Viswas, for sharing your knowledge, and thank you for coming on our channel. Thank you, Dr. Viswas.
Thank you so much. Thank you so much for having me with you. You guys are doing a great work. I really